A patient presents with a painful oral lesion. Most often, the clinician sees a collapsed open ulcer, but the clinical presentation of an ulcer is rarely the starting point of the pathology. Healthy stratified squamous epithelium relies on a complex network of intercellular connections and anchoring proteins to maintain structural integrity against constant oral wear. Before the tissue fails and ulcerates, it first elevates. Fluid accumulates within or beneath the cellular layers, forcing the epithelium upward into a circumscribed dome. Establishing a definitive diagnosis requires identifying the specific structural failure that preceded the tissue's collapse. The path toward a diagnosis begins with a physical measurement, the diameter of the lesion. This graphic compares the two primary categories of fluid-filled lesions. If the elevated structure is less than 5 mm in diameter, it is classified as a vesicle. If the accumulation of fluid causes the lesion to exceed that 5 mm threshold, it becomes a bulla. These fluid-filled domes are inherently fragile. The constant mechanical stress of mastication, combined with the friction of the tongue and teeth, quickly tears the epithelial roof away, leaving the open ulcer. Morphological size provides the initial categorization, but a definitive diagnosis requires identifying the underlying cause of the failure, which typically originates from one of three pathways: viral, immunologic, or hereditary. The first etiologic pillar is viral disease. Pathogenesis begins at the cellular level. A virus breaches the epithelial cell, altering the nucleus and causing rapid swelling that leads to acute structural lysis. The physical destruction of these infected cells creates a microscopic, fluid-filled void. Clinically, this manifests as a vesicle. Because the virus rapidly hijacks adjacent cells in a localized area, these vesicles typically emerge simultaneously in grouped clusters, often referred to as crops, and rupture rapidly. Primary herpetic gingivostomatitis provides a clear example. The tissue is marked by multiple coalescing vesicles that quickly break down into painful, fibrin-coated ulcers. The timeline for this viral mechanism is acute and self-limiting. As the host mounts an immune response, the lesions typically resolve without scarring in 10 to 14 days. Secondary herpes behaves similarly. Reactivation of the latent virus results in a localized cluster of vesicles, frequently seen on the hard palate. A biopsy confirms the mechanism. Infected epithelial cells exhibit specific histologic hallmarks, including multinucleation and the margination of chromatin along the inner nuclear membrane. Viral lesions present as acute, clustered vesicles, driven by cellular hijacking and rapid physical destruction from within. The second pillar, immunological disease, operates on a different timeline. These are chronic conditions driven by an autoimmune attack on the body's own structural proteins. This diagram illustrates the anatomical targets. Epithelial cells are anchored to one another by desmosomes and tethered below by the basement membrane. In immunological diseases, autoantibodies target and dissolve these desmosomes, stripping the cells of structural adhesion. When the autoimmune response specifically attacks a desmosome-associated protein called desmoglein 3, the resulting disease is Pemphigus vulgaris. Destroying the desmosomes severs the connections between adjacent cells. This creates a suprabasal intraepithelial separation, a pathological process known as acantholysis. Because separation occurs high within the tissue layers, it yields large, flaccid bullae with extremely thin roofs.
They rupture immediately, leaving irregular, map-like erosions. The shallow cleavage plane creates an extreme structural fragility. Gentle lateral traction on clinically unaffected mucosa will cause the epithelium to physically strip away, a clinical indicator known as a positive Nikolsky sign. Pemphigus vulgaris presents with severe, easily ruptured bullae because the structural failure is isolated to the uppermost, fragile layers of the epithelium. We can observe how the exact site of the attack alters the clinical presentation by comparing pemphigus to mucous membrane pemphigoid. In pemphigoid, autoantibodies bypass the desmosomes entirely. Instead, they target basement membrane antigens like laminin 332 and BP180. The intercellular bonds remain intact. Separation occurs at the foundation, lifting the entire epithelial layer cleanly away from the underlying lamina propria. This deeper failure is defined as subepithelial cleavage. Because the fluid accumulates beneath the entire epidermis, the resulting bulla has a thick, full-thickness epithelial roof. This extra tissue thickness provides durability. These subepithelial bullae present clinically as tense, fluid-filled structures that can remain stable for days before eventually rupturing. Identifying the exact anatomic cleavage plane dictates the physical behavior of the blister, informing the clinician about the severity and chronicity of the underlying disease. The third and final etiological pillar is hereditary disease. This mechanism is devoid of acute viral lysis and lacks the circulating autoantibodies seen in immunological conditions. The pathogenesis stems from a congenital defect. As seen in this magnified view of the basement membrane zone, the body simply fails to produce the necessary structural anchoring proteins, such as type 7 collagen. Epidermolysis bullosa is the primary disease category defined by the absence of this genetic adhesive. Without these inherent structural anchors, the tissue layers possess virtually no mechanical shear strength. Ordinary friction from eating or swallowing immediately separates the tissue. This results in severe, trauma-induced bullae. The mechanical stress of daily life generates a continuous cycle of extensive, painful ulcerations. Because the genetic defect is systemic, this extreme fragility extends far beyond the oral mucosa, producing cutaneous blisters and dystrophic nail changes on the extremities. Hereditary blistering conditions inflict lifelong trauma because the vital architectural foundation of the tissue was never properly coded in the patient's genome. We return to the clinical reality, a patient presenting with a painful, nonspecific mucosal ulcer. This matrix organizes the three mechanistic pathways that lead to an end-state ulcer. Viral diseases rely on cellular lysis, driving acute vesicles. Immunologic diseases use targeted autoantibodies, determining the cleavage plane of chronic bullae. Hereditary diseases rely on congenital fragility, causing lifelong lesions. The diagnostic process relies on tracing the physical presentation of the ulcer back to its specific anatomic and etiologic origins. Correlating the clinical presentation with the correct mechanism is the only method to implement targeted therapy, whether that means allowing a virus to clear or prescribing heavy immunosuppressants. In oral pathology, surface appearances deceive. Securing a definitive diagnosis requires understanding the precise architectural failure occurring deep beneath the mucosa